Good afternoon, everyone, and welcome to the Board of Pharmacy's webinar today. I'm Tom Glinsky, the Chief Inspector. Our topic today is a compliance update followed by a question and answer session. With me today is Inspector Andy Miller. If you don't know Andy, she is our inspector in the Kansas City area. Central and Northwest Missouri. She covers a wide area. We also have Dan Vanderson. He's our inspector in the St. Louis area and has some counties up in northern Missouri also. Today's program's been approved for 1 hour continuing education. Computer sharing is not allowed if you want CE. You must be signed into the webinar under your own name to get CE. At the end of the webinar, I'll go over this instructions on how to get CE. Just a reminder, the board does not submit to the CPE monitor, so make sure you save your certificates that we email you. If you haven't, handouts today are on the board's website under the upcoming events, or you can go to the GoToWebinar toolbar and you can see a link for them and click that to get today's handouts. And go back a slide because I think I missed one. You're in listen only mode. If you do have any trouble with audio, on the toolbar, you do have an option to switch from computer to phone call, and it gives you dial-in instructions if you need that. We do record our webinars and we post them on our website. It can take up to 15 days before they're available though. And since we are doing a question and answer session today, if you do have any questions for us, go to your webinar toolbar, type in the question and hit send, and we will get to those in the question and answer session. So today I have the webinar broken down to, I'm going to give a brief just summary of some of the inspection trends we've been seeing. We'll talk about some of the current topics going on with the board and give you some answers to some common questions there. And then a few slides of just, these are some of the frequently asked questions we get, and we'll answer those. And then we'll open it up to the whole group for a question and answer session. So what I did was I surveyed the inspectors and asked them to give me their top three, what they thought the top 3 observations they saw. And so that's how I compiled this list today. So these are in no order on how they were ranked. So unsanitary conditions is something that we see. Examples would be dusty and dirty shelves or the products on the shelves. Trash or debris on the floors, or could be loose tablets on the floors. The sink is always can be a concerning for sanitation, dirty, unkept sinks. And then the reconstitution device is always an issue for sanitation. So I've been told in the past people like when I show photos of things, so I've included some photos today of some of the things inspectors have found recently on inspections. Here's a couple examples of what we're talking about dirty shelves and product. When the inspector can write in the dirt, it's time to do some cleaning. There's some other pictures of just dirty shelves we've come across. There's a couple photos of just debris, pills, other things on the floors. There's a close-up of, I'm not quite sure what all we're looking at there. It kind of looks like a smashed tablet maybe on the left there. But those are some examples of floors. Usually I show pictures of the tips, the reconstitution tips. Today I'll show you the underneath side of some of these. This is what they look like underneath. A lot of people don't get down that low to see. but the inspectors do. So here you can see a wide variety of splashes up there, and a variety of colors. And then here's another one, the underneath side of that. So not just your tip, and this one says change tip to avoid contamination on the picture. That's not the only thing. You need to be making sure the whole thing's clean. Expired product in active inventory, it's common. It may just be one or two. Sometimes we find many more than that, but it could be all types of product. It could be stock bottles. It could be product in the robots. It can be repackaged product for some reason that has been repackaged. Return to stocks is a common one. Keep in mind, return to stocks expire from 1 year from the date they were dispensed, unless the manufacturer's is less than that. And then bubble cards for nursing home pharmacies, we'll see those expired. And then don't forget about compounding ingredients. That's a section that a lot of times gets overlooked, that we find expired stuff in there. The whole pharmacy may be perfectly clean of expired product, but they forgot to do a section, the compounding ingredients. So don't forget that when you're doing your checks. So here's a photo of what during one of the inspections, inspectors collected all those. Those are all expired products out of someone's inventory. Another issue, and we see this a lot, we've been talking about it for a couple years now. It continues to go on of finding cracked flavor bottle lids. Here's a couple examples. But again, we probably once a month we find a couple of these somewhere in Missouri that they just crack over time and they need to be replaced. Some patient counseling issues that we find on inspection, the failure to offer counseling. We find that out there. Keep in mind, you have to offer counseling on both new and refill prescriptions. We have some pharmacies that aren't offering it on refills, but maybe just on new ones. And also don't forget for mail out and deliveries, there needs to be a written offer to counsel sent with that package if you haven't verbally offered it to the patient over the phone. We'll go in, and some pharmacies have it automatically print on the receipts, and so that automatically gets in there. Others don't have that. They may have a pad or a stamp they use, but when we go in, they can't find the pad, so we kind of question, you know, is it really being used all the time? So just make sure that's covered. We also see it happening in just different parts of the pharmacy. We may see it at the regular pickup counter, but we're not seeing it offered at the drive-up window, or if you're using a tube, maybe at the tube. So just make sure all parts of the pharmacy are offering that if you have multiple pickup areas. Technician answering drug-related questions. We see sometimes that where a technician is asked a question, or maybe to recommend an OTC product for a specific symptom or something, and they just automatically are answering that question. Only a pharmacist or a supervised intern should be providing counseling at the pharmacy. And then technicians relaying information to patients instead of the pharmacist. As pharmacists become busier, pharmacists asked to do more. I think we're seeing more times where instead of the pharmacist actually having the conversation with the patient, information is being relayed through the technician to the patient. So the technician comes to the pharmacist, asks the question, gets the answer, and then goes back to the patient and talks to the patient about it. We see that at drive-up windows too, where because some of the setups where the pharmacist isn't close by the drive-up window some of the times, and it's this technician just relaying information back and forth. Some controlled substance and pseudoephedrine issues. Still seeing e-prescriptions converted to fax. DEA says that a controlled substance prescription that's e-prescribed must stay electronic. It cannot be converted to fax. The examples we see, probably the most common one is the prescriber doesn't have a system that does true prescribing. They enter it on their computer, but instead of the computer sending it electronically, it just automatically faxes to the pharmacy. I've had reports other times is when the intermediary between the pharmacy, the prescriber and the pharmacy goes down, their system might automatically just start kicking it out as fax. That's fine for a non-controlled, but for controlled substances, that wouldn't be valid. Refill transfers not being handled between two pharmacists. We see that on occasion. Late or incomplete annual inventory. Missouri is a state that requires an annual controlled substance inventory. As with a lot of things that come, on a schedule, put it on a reminder on a calendar or in your phone, and that way you won't ever be late. Incomplete, it's usually you're just overlooking something. I think we're much better now knowing we have to inventory the over-counter pseudoephedrine, but that was probably the #1 culprit in the past. And then unable to access the pseudoephedrine cells or the NPLEX database. On inspection, we will always ask to pull those cells up either on your internal system, your point of sale system if you're doing it internally, or on the NPLEX website. A lot of times people don't know their logins. I mean, maybe the pharmacist that is helping us do the inspection probably doesn't get on there very often, and they don't know their logins. So just make sure everyone knows how to access that. Another thing inspectors mentioned was the labeling of compounds. Our regulation requires that the patient container contains all the active ingredients. It doesn't have to be on the prescription label. It just needs to be on the container somewhere. It's still okay to use the term magic mouthwash in your computer and on the label. You just need to make sure you have all the active ingredients listed somewhere on that container. And then you can't abbreviate your active ingredient names, especially these compounds that have 5 or 6 ingredients in them, and we're seeing them abbreviate, using the first 3 letters of drug names to get it all in there. So again, it doesn't have to be the name on the label. It just needs to be somewhere on the container going to the patient. And then another thing we see, and again, the magic mouthwash is probably the culprit here. When you are labeling with the ingredient names, it needs to be what you're actually using. We see times magic mouthwash is listed as having Benadryl in it or Mylanta, but when we look at the compounding log, they're using a generic version of that. So make sure you are accurately listing what you're using there. Quality assurance reports. If you don't know, on inspection, we look at prescription records, and when we do that, we come across sometimes possible dispensing errors. When that happens, we issue a quality assurance report. It details what that possible error was, and then we ask the pharmacist in charge to answer some questions about that. So some data below for fiscal year 2019-20, so that ended in June 30th of 2020. We issued 338 of those on inspection. If you look at the chart down there, that number has been growing, and due to COVID, that number would have, if it wasn't for COVID, that number would have been higher because the inspectors were not out inspecting for 7 weeks during that fiscal year. So that the number has been climbing over the years. On the right is a breakdown of what we're seeing, what kind of, we type them on what kind of error is it. As you can see, the vast majority of them are incorrect directions. However, we do find where it appears the wrong drug or strength were given out, or at least one time we found it, the prescription was entered under the wrong patient. Of those incorrect directions, PRN issues are the most common. That is when a doctor writes PRN, but the prescription is dispensed without that on the label, or vice versa, that it was put on there when it wasn't prescribed that way. A lot of times those are due to carrying over old prescriptions that the patient had before and the doctor made a change, and the pharmacist isn't catching that. So for sterile compounding, the top three were late or incomplete aseptic skill assessments. Either they just didn't do them on time, required annually, or they're just not covering all the topics that the rule requires. Blocking first air is a common thing we see when we're watching people actually doing the compounding. They're blocking first air in how they're doing it. And then failure to maintain or clean the primary engineering control or controlled buffer area properly. So I have some photos here for those. Rust is a common thing we see. Keep in mind you're always cleaning these with liquids. Those lead to rust buildup. So watch for rust. Just normal wear and tear. I believe the top left picture is probably, my guess is that they probably use a card or something that is hitting that as it goes by. The bottom left is just wear and tear on a hood where the paint is chipping. The bottom right is an example of floor cracks that need repaired, and the top right one there is a ceiling tile. So I don't know if that's wear and tear. It looks like there's damage up there that somehow it got punctured. But those are all things that need to be fixed in there, properly maintained. Cleaning, here's examples of two. I'm making the assumption these are probably the primary engineering control, the behind them. These are examples of that area not being cleaned properly. These show dust on vents, so probably vents on the PEC. The top one shows not only dust, but also the paint is chipping on that. Here's an example of just a dirty floor in the room. And this is an example. I believe they use some kind of caulk is what that is on there to seal something, but you can see there's a lot of stuff. I don't know if that's down below, if that's rust or what the brown stuff is on the caulk. And then if you notice, the metal is coming apart there, creating an area that probably cannot be properly cleaned underneath that screw area in there. So those are just some examples. Oh, one more. Here's looking deep inside a spill tray. You'll see some yellow stuff on kind of the right side inside, and then if you look farther deep down, there's some kind of white stuff in that spill tray. So proper cleaning is important in there. One tip I have is when I talk to inspectors, they say, you know, one of the things that takes the most time is waiting for people to find what I need. So if you want to have less stress on you and your staff and quicker inspections, know where things are. We have the records locator. I'll show you a picture of it in a second, but it's on our website. It's in the inspection handout folders we give out. I recommend you make sure your staff, relief, or floater pharmacists all have one of those and know where things are kept. This is what it looks like. It lists all the records that we had asked, most of the records we had asked for, and you just write where you would locate them, and that's way your staff can find them easily. So some of the current topics going on right now in Pharma with the board, it is renewal period. We've had lots of questions on continuing education. So what is the requirement for this renewal period? It was lowered due to COVID to 15 hours. A lot of people want to know, I've already done my 30, can I carry them over to the next renewal period? The answer is no. The 2 hours for the immunization by protocol has been waived. So if you're unable to get that accomplished, you can still renew your NOI, notification of intent. Two requirements that were not waived was the 6 hours for medication therapy services, or MTS, and the 4 hours for Class M. A lot of people, will I be audited? Yes. We went to a new system where actually you don't know it, but all pharmacists are audited. The board will check the CPE monitor. And if that you don't have 30 hours there, then we'll look to see if we issued you any CE. And between the two of those, if they're still not 30 hours, then we'll be sending you a request to provide proof of your CE. What counts for the MTS CE requirements? Well, we'll accept any CE related to drug therapy or disease state management. The easiest way to identify those is look at the ACPE code. If it has an 01, and here's an example of what that code looks like, an 01 means it's drug therapy related, and we would accept all of those. Who needs CE for Class M? So this is a two-part. It's an and here. You have to be engaged in dispensing or counseling on blood clotting factor concentrates, and the pharmacy you work at has to meet one of these two requirements. They either are servicing established patients, and an established patient is a patient who has received product on more than 3 occasions in a single calendar year from your pharmacy. So if you're at like an outpatient pharmacy who does discharge prescriptions and that's the only prescription they're going to get, they are not an established patient. If it's not established patients, but if you're offering or advertising this blood clotting products to, that would trigger it also. So this is a two-part. You have to meet both of the ands, and then the second part is it's either of those would trigger the pharmacy part of it. So if you work at a Class M pharmacy, not all Class M pharmacists need it. It all depends if you're meeting these definitions here. So what counts for Class M? It's any CE related to factor concentrates, infusion therapy, or blood clotting disorders or diseases. So it's wide open there. I don't have any special codes that you can use. COVID-19 is still a hot thing. So will I be able to administer the COVID-19 vaccine? The answer is yes. Under the HHS declaration, you will be able to do that. The board is seeking waiver from the governor to allow you to do it under a protocol with the Missouri licensed physician or under a statewide standing order with the Department of Health physician. When do Board of Pharmacy waivers, COVID waivers expire? They expire on 12/30 of this year. However, I can't tell you that for sure on the HHS declaration. I don't know the exact end date for that one. So, but all the other ones will be on 12/30, and the governor will have to be the one that makes a decision if waivers are going to be extended. So we can't answer that for sure. I'm going to let Andy answer some of the common questions we have for immunizations.
All right, so we've been getting a lot of questions about whether or not pharmacists can provide childhood vaccines to children ages 3 and up currently. So technically the answer is yes, under the HHS's Third Amendment to the Declaration under the Public Readiness and Emergency Preparedness Act, the PrEP Act, which temporarily expands the practice of pharmacy to include childhood immunizations for kids aged 3 to 18. In Missouri, there's 3 different pathways you may choose to do this. One of them, under HHS's authorization, you may choose to administer strictly under that authorization, in which case the pharmacist who administers would be listed as the prescriber. We understand there may be some billing difficulties with these, but that's not under the jurisdiction of the board, so you'd have to seek out additional information on that if you choose that pathway. The second pathway would be through a statewide standing order, in which case the doctor signing that statewide standing order would be the prescriber on the prescription. We do not currently have a statewide standing order yet, which is in process, and we understand it's very close to being finalized, so you'll just need to stay tuned to the board's e-alerts for more information on that. And the third pathway in Missouri to administer the childhood vaccines to children aged 3 currently would be to amend your current protocol with your protocol physician to add whichever childhood vaccines you plan to administer and the age groups you plan to administer. And then in that case, your normal protocol physician would be the prescriber on those prescriptions. So otherwise, we're getting a lot of questions as well on whether or not pharmacists can administer vaccines in the parking lot. So yes, the answer is you can do that. However, the board does recommend considering amending your protocol to mention that these are going to be administered in the parking lot. And you also may want to consider other factors that may be referenced in your protocol, such as patient observation. Our rule does require that you specifically state in the protocol how long the pharmacist is going to recommend the patient be observed by the pharmacist following their vaccine. So it's going to look very different if the patient's in a car. And also you're going to want to consider vaccine storage, since you're going to be out in the elements and the temperature is likely not going to be within the range that the vaccine should be stored. Finally, we're starting to get a few questions about whether or not pharmacies can use nurses to provide immunizations. So generally for the question you're probably asking, the answer is no, not under the pharmacy's protocol. And if a nurse were to administer the vaccine, you could not generate a prescription based on that and for billing purposes. You could, as a pharmacy, host an immunization event which had nurses administering them, but remember, you can't, the nurse would be doing that under their own protocol, and you cannot use your own or physician protocol or make a prescription from that.
Okay, thank you, Andy. We're now just going to do some of the other frequently asked questions. Andy and Dan are going to do these next slides. So first one's dealing with controlled substance, some common controlled substance questions we get asked.
One question we still get is, do I need to sign and date my hard copy prescriptions? The answer to that is no, you're not required to, as long as the pharmacy's computer system retains that data dispensing and the pharmacist's identity. Another question we get is, can controlled substances go in multi-med packs? The board recently changed a rule that allowed that to happen, so you can put controlled substances in multi-med packs. And when they changed that rule, they also changed that there was a requirement, it was 60 days, and that has now gone to 90-day beyond use date. So you can assign a 90-day beyond use date for multi-med packs as well. This one we've seen quite a bit of. If sharing a common database, does a transfer still need to involve two pharmacists? The answer to that is yes. Both board rule and DA rule require communication between two pharmacists anytime you transfer a controlled substance. This one, especially in certain areas of the state, has been a big question too. With can I still require a prescription for Sudafed? The answer to that is no. The new statute does not allow you to require a prescription for Sudafed products. There's some municipalities and counties that had been restricting this, and they no longer allowed to do that. It goes along with that. Can a patient, can you still take a prescription if a patient presents one? Yes, you can. And sometimes they want to do that for, insurance purposes or Medicaid, or they may be above the threshold, the limits and things like that. Next question, if I can only get 10 ml vials of testosterone, can I dispense those if more than a 90-day supply? This is a BNDD statute, and according to BNDD, the answer is no, and that applies even if it doesn't come in a smaller package size. So there's a statute out there, and it's a hard statute that limits 3 through 5, Schedule 3 through 5 prescriptions to a 90-day supply. Next question is, for Schedule 2 drugs, is a diagnosis code an acceptable reason for more than a 30-day supply on a C2 prescription? The BNDD has provided in the past that in order for it to be a 30-day supply, a diagnosis code is not a sufficient reason. And then a few other examples that they've given, a chronic pain wouldn't be sufficient either. If you use something, it has to be a medical reason. So something like they provided examples in the past, cervical pain unresolved by surgery or stabilized ADHD would be sufficient. So if you have any controlled substance questions or want any further clarification on those are BNDD statutes. So we'd refer you to them to, for an answer.
Andy, you'll take some we get on compounding.
All right, so earlier Tom mentioned that all of the active ingredients must be listed on the container of a compounded product a patient receives, and that they cannot be abbreviated. So especially with some of these compounds with 5 or 6 ingredients in them, or even magic mouthwash with the limited bit of real estate that you have on a prescription label, this can be a challenge. And this question comes up a fair amount of what if there's not enough room on the label for the full active ingredient names. So the first thing I would recommend you do is contact your software provider and see if that's actually the case. It may not look like there's enough room on the label, but they do have ways of moving those around and customizing them. So maybe not all software providers can do this, but some of them can, and that really helps. Other options are you could include the ingredients in the SIG. Just make sure that all of the inputting staff knows that it needs to be included every time. Pharmacies that choose this route, it is probably the most easily forgotten method to put the active ingredients on the bottle. Other options are some software systems allow you to design and print your own auxiliary labels, so that's a great option. Or if that's not a possibility, you may consider just buying some office labels from your local office store and pre-printing up, if you only make 3 or 4 compounds over and over, you list out the ingredients for the Magic mouthwash or the Bum Balm or whatever it is you're making, and just have those available pre-printed in your compounding binder to put on the bottle each time you make that product. And if none of these options work for you, you can neatly handwrite the full active ingredient names on the label or on just anywhere on the container. Remember, it does not have to be actually on the label. It can be on the auxiliary label as long as it's on the container that the patient gets. Also comes up frequently is when can a commercially available product be compounded? So I just want to clarify what commercially available includes or doesn't include. If a patient is prescribed a liquid formulation and the drug product only comes in a solid form, then that liquid form is not considered a commercially available product. It's the formulation that doesn't exist currently on the market. However, if you do want to compound a commercially available product, it can only be done under certain circumstances. If that product is not currently available from your wholesaler, we would say that that is a reason that you could compound, and you don't have to check around to all your neighbors' wholesalers as well. If it's just your wholesaler that doesn't have it, that's fine. You can compound that commercially available product. Also, if the patient has some sort of medical reason that would prohibit them from being able to safely consume the commercially available product, such as they have an allergy to a particular oil or a dye used in the commercially available product, that would be a legitimate reason to compound that commercially available product as well. So what kind of documentation do you need if the commercially available product is out of stock? Our rule requires that sufficient documentation within the prescription record of the pharmacy of specific medical need for a particular variation of a commercially available compound. So an example of this might be if your wholesaler is out of a product, just print off that page that shows it's out of stock, include that with the prescription record, the compounding record, and that would be sufficient documentation. Otherwise, on a prescription record, you could have the doctor mention that patient's allergic to red dye or whatever the product is they're allergic to. That would be sufficient as well. We're already getting a few questions in on this webinar about whether compounding kits are considered compounding or commercially available products. Compounding kits are not FDA approved, so those are not considered a commercially available product and therefore must be entered in the compounding log as a compound. They're strictly a convenience aid for billing and mixing to have the ingredients on hand. Reconstitutions like Benzyklin or antibiotics or whatnot, those are FDA approved products. So reconstituting the Benzyklin or the antibiotic is not a compounding process and therefore would not need to be in the compounding log. And pharmacies often wonder if they want to start compounding, do they need to add Class D non-sterile compounding to their permit in order to start compounding? And the answer is not everybody needs to do this to compound. Most pharmacies I come across don't actually need this. It's only required if a pharmacy plans to make a product from any bulk active ingredients in a batch quantity. So if you're using bulk active ingredients, this is going to be like your USP grade powders or liquids. It's not going to be like a Magic Mouthwash, you're mixing 3 commercially available products together to make 1 single compound. So it's bulk active ingredients for a batch quantity.
Okay, thank you, Andy. Dan's now going to just handle some of a few miscellaneous ones we get.
All right, a few miscellaneous ones we get are one being our telehealth visits by Skype or some other method allowed in Missouri. The answer to that is yes. Missouri pharmacy may fill a prescription that is issued based on a valid telehealth or telemedicine exam. To be a valid telemedicine prescription from a Missouri prescriber, that prescriber must be licensed in Missouri, and the prescription must be based on a valid patient-prescriber relationship, and the prescriber must comply with any controlled substance laws, and the telemedicine services must be within the provider's scope of practice. Can I store my wholesaler invoices electronically? Yes, they can be. Just when we go out to inspect you, they need to be retrievable during an inspection. And the Schedule 3 through 5 invoices must be dated when received. We'll get questions. Well, how do I date a C3 through 5 invoice? If it's electronic, but you need to talk to BNDD on what an acceptable way to date your invoices would be. Can I have an agreement with a physician to allow me to perform therapeutic substitution automatically? In general, the answer to this is no, but it could possibly be done under MTS if you follow all of the MTS requirements. How long can a technician applicant work before getting their license? That technician application serves as the technician registration until the hard copy arrives. I would say, if it goes past a couple months, the board office is real efficient about getting these out. But if it goes longer than a couple months, you want to check with the board office to see if they actually received the application. We have had instances where, it ends up being stuck in somebody's trunk or somebody's car or somewhere like that. And as a PIC, it's your responsibility. You want to make sure it actually gets to the board office, and that, if you're trusting somebody to send it, that they actually send it. Last question I have: can I break boxes of insulin pens? The board rules would not prohibit this, but any mandated patient literature would need to be provided if it was required. And the board, a lot of people do this for billing purposes, and the board doesn't provide any guidance on, the proper way to bill it through insurance.
Okay, thanks, Dan. We're now going to open it up to our question and answer session. So if you have any questions for us, go to your webinar toolbar and submit your questions. We're going to start with the ones that came in advance, since we asked you to send them in advance. So Dan and Andy are going to start us off.
All right, so the first question is, does the 50-mile rule from your practice location for MTS, medication therapy services, apply for a pharmacist practicing with medical staff approved, with a medical staff approved hospital protocol? So if the MTS is being used for activities under the Department of Health jurisdiction, so inpatient activities, the board's rule, including the 50-mile limit, does not apply. So if this is under the hospital protocol and you're doing it at the hospital licensed DHSS jurisdiction, you would follow DHSS's rules on that. Related to that, we had another question stating our health system has requested that pharmacy personnel, both hospital and retail based, assist with employee flu vaccine clinics hosted by the health system. What is the Board of Pharmacy requirements in regards to this? So if the pharmacist is providing immunizations within that Department of Health licensed hospital premises, this again is going to fall under DHSS jurisdiction. So you'll need to contact DHSS for any guidance on that. If the clinics are outside of the premises, however, all board requirements would apply. But regardless of jurisdiction, just want to remind you that 338.010 does require reporting to the Show Me Vax system, unless the patient opts out, in which case you'd be required to report the vaccination to the patient's PCP if they have one.
Another question that came in, is a log required for refrigerator and our room temperatures and humidity where medications are stored? The answer to that is the board only requires refrigerator and freezer temperature logs for Class H sterile compounding pharmacies. We can't speak to other agencies' requirements on that. Can a pharmacy meet security requirements without an alarm system or cameras inside the pharmacy? The board's rules do not require an alarm or cameras, but recommend a pharmacy consider them as part of their overall security. The one exception, the new Class R remote dispensing site rule is that exception, and it requires an alarm. A pharmacy that also holds a drug distributor license is required by their drug distributor license to have an alarm.
All right, we got another question about pharmacy technician and intern pharmacist supervision. So we have a sterile compounding pharmacy that's contacted us that states they use technology to monitor and record the sterile compounding process. And they're wanting to know if this supervision model is allowed under 2.710. So they note that the pharmacists are verifying the final product on site and inspect the final products, but part of the verification process is looking at those photos that were taken during the sterile compounding process. So in general, except for the new Class R remote dispensing sites, technology cannot be used to perform the final product check. However, in this scenario that was presented to us, technology is not being used to perform the final check since the pharmacist is personally verifying it. Therefore, there's nothing wrong with them using technology in the supervision and compound record keeping process there.
Another question that was asked ahead of time is, can certified technicians prep shots for immunization? And then they put in there not mixes and Shingrix, but attach needles to pre-filled shots. Board rules do not prohibit a supervised technician from performing that, and that includes the reconstitution part of it too, that a technician can do that as well. I think the last question that was asked ahead of time, can I put an over-the-counter product in a multi-med pack? The answer to that is yes, but you need to have a valid prescription for that OTC item in order to meet the rule requirements.
All right, we've been receiving some questions throughout the webinar, and we want to get to those as well. Let's see here. I have someone asking to clarify regarding the bulk ingredients that may be used and whether Class D is required. So the rule is you're using bulk ingredients and it's for a batch quantity that you would require a Class D license. If you're using bulk ingredients for an individual patient's prescription, then Class D would not necessarily be required. But if you're using bulk ingredients and making batch quantities, you would need that.
We have a couple people wanting clarification on breaking insulin boxes, saying the FDA issued something on that. As we said, the board wouldn't prohibit it, but if another agency prohibits it, you would need to follow their guidance on that. That sounds familiar, but I can't speak to that right now, what FDA issued. Someone's asking about, is there a COVID waiver in effect if you can't get your CPR requirement for immunizations? There is, but it only applies if you need to renew a CPR, if you're a new pharmacist and are not able, who have not filed an NOI before, it does not apply to that. So there is one in effect for renewing an NOI if you don't have your CPR. We highly encourage you to get it done as soon as possible. A pharmacist told me they just did it not too long ago, and there was open seats in the room. So I think it all depends on the area where you're at.
All right, and I have someone that's asking about the Magic Mouthwash kit. Can you compound a Magic Mouthwash prescription that's available in a kit? absolutely, you may choose to use a kit if you want. Just remember that it is a compounded product and you'll still need to log that in the compound log, and all the individual ingredients from that product will need to show up on the patient's container. All right, another question came in. If a 10 milliliter vial of testosterone is labeled as discard after 90 days, will this allow dispensing? The Beyond You state would not recommend using longer than 90 days. Again, this is a BNDD jurisdiction issue. We have asked this in the past and have been advised that that is not a loophole that can be used, that if it would technically, mathematically end up to being more than 90-day supply for that patient, then it cannot be dispensed.
Another question we had is, are there any plans in place to replace hard copy cardstock licenses with electronic licenses that can be accessed online? You can verify a license online, so there's no plans to replace those hard copy licenses at this time, but you can access to find out whether a technician or a pharmacist or a drug distributor or pharmacy or drug outsourcer or third-party logistics provider, all that's available online on our website.
We have someone asking about when can we apply for a remote pharmacy site. So I believe they're asking about the new Class R remote dispensing site. The rules are in place. I am told the application will be available very, very soon. So just keep watching our, I'm sure we'll put it out on an email alert, but we expect that to be any time now, have that application. Once the application's out there, you can apply if you would like.
All right, another question. If a prescriber writes for a dose of half of a tablet that is not scored, can the pharmacist half the strength and double the quantity without contacting the prescriber? So not all tablets that are lacking scoring are prohibited from being scored. You'd have to look into the individual prescribing, dispensing information with that. However, our rule does require that you contact the prescriber for any changes in strength or quantity. So you would need to contact the prescriber and document that interaction on the prescription record.
We got someone again wanting clarification on the insulin boxes again. So the answer is the board doesn't prohibit it, but we have some people saying FDA issued guidance on not doing that. I cannot verify that right now, but if that is true, then you would need to be following FDA guidance on that. So you need to look into that and see what FDA did issue on that.
All right, another question asking, can a C3 through 5 prescription be filled more than 5 times as long as the total quantity plus any refills is not exceeded in 6 months? We've asked BNDD about this one in the past. They do not consider partial fillings as a full dispensing. So yes, as long as you're not exceeding that 6-month time period from the date that the prescription was written or the total quantity prescribed, then it is okay to dispense partial fills of a prescription. This comes up a lot with Suboxone or whatnot, and that is fine.
Have a hospital asking if they have a protocol for nurses to give flu shots, can a pharmacist be added to it? This will all depend on if it's happening within the Department of Health licensed premises. This would be, that protocol would be under their jurisdiction. You would need to ask the Department of Health on what's required for a protocol to be used within a hospital. If it's outside the hospital in the board's jurisdiction, no. Well, the answer could be yes if that protocol has everything that's required for a pharmacist protocol. The nursing protocols I've seen probably would not have that, everything that's required by a pharmacy protocol.
Another question we had was, am I required to keep hard copies of prescriptions if they are also kept electronically? The answer to that is, if you comply with our electronic record keeping system rules, you can keep those non-controlled prescription electronically, as long as you follow those requirements.
You can also do, we don't differentiate between controls. If you're allowed to not have one by the DEA, then our rule would also allow you not to have one. But the DEA does still require for written and faxed controls to maintain a hard copy is our understanding from the DEA. Someone wants to know, does the board still issue 50-year golden certificates? Yes, we do.
All right, got another question. Says, please revisit the prescribed controlled substances. C2 cannot drop to fax, but can C3 through 5 drop to fax. I think what the listener is asking is if the controlled substance prescription is kicked over to the fax machine, they know they cannot accept the C2s that came over. Can they still accept the C3 through 5s that came over via fax? The answer is no. If you're receiving a C3 through 5 prescription via fax, it has to have a wet signature from the prescriber on that. An alternate to, if you do not have that wet signature on that, you can call the prescriber for a C3 through 5 prescription and get a verbal prescription, and you can just document that on the fax you received, and that will fulfill your requirements there.
One question we got in, does the board still require a logbook to be signed daily by pharmacists on duty? That's not a requirement of the board to do that. The DA may have some rules about that, but that's not a board requirement that you sign a logbook on a daily basis.
Yeah, the DEA still required if you're doing refills and using a computer system that a pharmacist sign the logbook. So it's a DEA requirement, not a board requirement.
Let's see here. I have a clarification question regarding multi-dose vials and any sort of limit, 28-day limit after puncture, and wanting to know if a 10 milliliter vial of testosterone could be a 28-day supply. And again, you'd need to clarify with BNDD on this, but per our previous communications with BNDD, no, you would have to just go straight math and divide the total quantity of the vial by the patient's daily, weekly, or whatever dose, and they do not take that 28-day BUD into consideration in enforcing their rule.
I got an update on the Class R application. I've been told that they will be available on Monday. So check our website on Monday.
Was asked a clarification question. Is chronic pain a valid medical reason for C2 to be filled for greater than 30 days? BNDD in the past has said that chronic pain alone is not sufficient.
All right, we've got several questions coming in on OTC Sudafed. Someone's wanting to know, do they have to sell Sudafed OTC? There's no rule that requires you to carry OTC Sudafed products. However, the patient cannot be required to bring in a prescription for that product.
Someone's asking for, can nurses, if the nurses are employees of the pharmacy, can they then administer the vaccine? Not under the pharmacist protocol. They could have their own protocol and come in and do it. And as Andy said, you'd kind of be hosting that, but they would have their own protocol. They would not be using the pharmacist protocol to do that.
All right, so there's someone asking if they are required to keep hard copies of prescriptions if they are also kept electronically. Short answer is it depends. For any controlled substance hard copies that you scan in electronically, you do still need to maintain the hard copies of those. Otherwise, as long as you meet all of the requirements of our electronic record keeping rule, then you can get rid of the hard copies of non-controlled prescriptions that you've received and stored electronically.
Someone asking if a hospital pharmacy is supplying the medications for other locations of the health center, do they need a distributor license or Class J? No, they won't, as long as they're distributing drugs to hospital-owned entities, they would not need a drug distributor license with the board. Someone's asking about allowing technicians to immunize. Is that something the board will eventually do? I don't know if they will, but they have talked about that. It has been up for discussion to look into that. So it may be coming in the future. Someone's asking for clarification on their NOI renewal, and they said they have an expired BLS and I think they have an expired NOI too. They want to know, do they have to get those renewed? You need to renew your NOI. If you can't get your BLS or CPR renewed, then that is waived since you say you have one in the past. And then they want to know, do I have to do the 2 hours of CE? No, that has been waived. So I think the question is, do they need to renew their notification of intent? Yes. Do they have to have a current BLS? No, because they had one in the past, but it's highly encouraged that you get it done as soon as possible. I think we're going to have to end. We're running out of time today. Thanks for everyone who sent questions in. If you have more questions, you can always look. A good source is the Missouri Practice Guide. It was just revised and updated in February. It's on the board's website. We also mailed out a hard copy to all pharmacies. I believe that was in April and May approximately, those got mailed out. You can always email your inspector. You can email the board office. You can submit, there's now mechanisms on our website to submit questions either to the board office or to inspectors. And then as mentioned earlier, if you have need more guidance on controlled substances, we recommend that you email them at bndd@health.mo.gov. As I said earlier, we do make a recording of this. It'll maybe 15 days before it's available. On our website now, we have all past ones. This year we had regulation update, 2 COVID updates, a BNDD update, a MoHealthNet update, and we just did a legislative update in August. So all of those are available for viewing on the board's website. If you want to get CE for today, you must complete the post survey at the end. So do not close your browser. After I announce that I'm closing the webinar, this little box will pop up, click close. Again, do not close your browser, and then the survey will pop up. You answer the questions and click submit. If for some reason you do not get the questions, we hear problems with cell phones and tablets sometimes not being able to get them. You can always email us at compliance@pr.mo.gov, and we will email you the questions, but you must have the answers back within 24 hours in order to get CE. We no longer mail out certificates, we email them out. So be watching for those. That, within the next 30 days, you will get an email with your certificate. So I want to thank everybody. I want to thank Andy and Dan for coming in today and helping answer the questions. I am now going to close